This is the last module of our education program. It's by myself, Brittany Hartman, and Samantha Dittmer. I'm going to start off by reviewing my infant toddler feeding modules. So first I'm going to review infant and toddler development. Every day, a baby is growing so quickly. Their growth is powered by good nutrition and strong feeding abilities. Feeding looks different at every age for babies and young children, but it is the intake of nutrition that helps them grow, develop, and thrive. Most babies begin life by breast or bottle feeding and slowly build up to solid foods. There are various feeding milestones a baby will meet throughout the first 36 months. The timing of these milestones varies greatly throughout development. If the baby has a developmental delay, it means they are slow to acquire their milestones. If parents use skill acquisition, meaning they continuously practice skills with their child to achieve the milestones, the baby could develop their milestones not long after their peers. So now I'm going to go over the natural development of infant feeding. What I have listed on the slide is just some of the developmental milestones I went over. I included what I thought was most important to remember. So from 1 to 5 months, the baby synchronizes the suck, swallow, and breathe patterns. From 3 to 6 months, they can swallow strained or pureed foods. From 5 to 6 months, they will mouth and munch solid foods, and this is also an appropriate age to introduce solid foods. From 8 to 13.5 months, the baby will chew foods with coordinated movements. From 9 to 12 months, they will finger feed themselves. And between 6 to 12 months, they will drink from a cup held for them. Listed on this slide is the natural development of toddler feeding. Again, these are milestones I discussed in the previous presentation and the ones that I felt are most important to note. So between 12 to 15 months, the baby will bring a spoon to their mouth and turn over the spoon. Between 15 and 23 months, they'll scoop food, feed themselves with a spoon with some spilling, and by 24 months, it's appropriate to encourage spoon and fork use for self-feeding. From 18 to 23 months, they'll distinguish between edible and inedible objects. From 18 to 24 months, they will chew foods completely. From 20 to 30 months, they will hold a small cup in one hand. From 29.5 to 31.5 months, they may reject many foods. And from 30 to 36 months, they will use a fork and napkin. Next, I'm going to review my module on breastfeeding. So a review on the benefits of breastfeeding. Breastfeeding protects against a variety of diseases and disorders such as diabetes, respiratory tract infection, and more. It also has immunological benefits such as enhancing an infant's immune function. Breastfeeding also decreases the risk of the baby developing SIDS, sudden infant death syndrome. Breastfeeding promotes secure attachment. Breastfeeding also has hormonal benefits, such as reducing the mother's risk of developing postpartum depression. Breastfeeding has physical benefits for the mother, such as decreasing the risk of breast and ovarian cancer. And breastfeeding also encourages oral motor skills and development for the baby. So moving on to reviewing positioning and latching. For positioning, you want to get comfortable and use pillows or cushions if needed. You want to make sure the baby's head and body are in a straight line. You want to hold your baby close to you, facing your breast. You want to bring the baby to the breast and let them latch. And you want to make sure the baby's nose is level to your nipple. For latching, you want to hold the baby close, again with the nose level to the nipple. You want to let the baby's head tip back so their top lip can brush against the nipple. Baby's mouth will open wide and their chin should touch your breast. And they're attached when the baby's cheeks look full and rounded as they feed. So some concerns with breastfeeding. The baby may have cleft lip or palate, which could make breastfeeding difficult. Um, Standard bottles or solely breastfeeding cannot create the suction needed to draw milk out of the nipple, but special bottles and nipples are available if your baby has cleft lip or palate. The baby may also be nursing for comfort if they are continuing to suck for an hour or more after getting milk. You can offer the baby their thumb or pacifier instead. There are many reasons the baby may stop nursing, but remember this is a hurdle that is temporary and there are ways to help. And if you feel pain during feeding, reposition the baby. Next, I'll review my module on toddler feeding. So for toddler positioning, the baby should be sitting independently on the floor before sitting in a high chair. They should be positioned at a 90-degree angle at their hips, knees, and ankles and have support under their feet. You don't want the child leaning to either side. If needed, you can add a rolled up pillow or towel. If the chair is too big, add a small towel roll behind their back for added support. You want to ensure the footrest reaches their feet, and you may modify with a tissue box, pool noodle, or other household materials. You can make the tray chest height or below for the baby to reach the food, and you never want them in a reclined position. So for toddler feeding and drinking, I went over that solid foods start around 6 months, and you want to get your pediatrician's approval before starting. Allow the toddler to get food on their hands and bring it to their mouth. You want to ensure that proper alignment and positioning in the high chair. You want to encourage your toddler to mouth objects like teething rings to prepare for chewing. You want to provide 2 to 3 spoons or toys to make mealtime engaging. And you want to provide small portion sizes at a time and introduce food slowly. For finger feeding, know what foods are safe. Again, run that by your pediatrician. Occupational therapy can help as well. Beginner foods easily melt in the child's mouth, and provide 1 to 2 pieces of food at a time. For spoon feeding, introduce the spoon as a play object during meals at first. Help your child guide the spoon using hand over hand method, and provide elbow support if the child needs additional help. For cup drinking, sippy cups work for some, but drinking from open cups, straw cups, or cups with a flat lid may be better. Fill the cup halfway and provide support when the child is first learning. If the child has difficulty with thin liquids, try thicker liquids. So a review on picky eaters. A child eats a limited variety of foods, is unwilling to try new foods, and/or eats slowly and deliberately, is a picky eater. They may have difficulties with feeding, which may relate to touch, taste, smell, or the coordination of the child's body or mouth and tongue movements. Children may be sensitive to certain food textures or tastes. So what can you do for a picky eater? You want to make food fun, explore new foods during play, slowly introduce new tastes at mealtime, reward even the smallest steps forward, give your child some control, stick to a routine, and consider calming and coping while eating, and more. Next, I'll review infant and child hunger cues. So what are the hunger signs? For a baby, they'll bring their fist and move it to their mouth. Their head will turn to look for the breast or bottle. They'll become more alert and active. They'll suck on their hands or lip smack. They'll open and close their mouth, and you want to watch for hunger signs early to prevent crying. For toddlers, they'll reach for or point to food. They'll open their mouth when food is offered. They'll get excited at the sight of food, and they'll use their hand motions or make sounds to communicate hunger. For fullness signs, a baby will release or fall off the breast or bottle. They'll turn their head away from the nipple. They'll relax their body and open their fists. And you can try burping the baby and then offer the breast or bottle again. And if the baby doesn't seem interested, then that could mean they're not hungry. For a toddler, they'll push food away. They'll close their mouth when food is offered. They'll turn their head away from food, and they'll use hand motions or make sounds to let you know they're full. I also reviewed responsive feeding. So what is it? Responsive feeding is recognizing and responding to child cues of hunger to support and maintain the child's innate capacity to self-regulate energy intake and avoid overfeeding. You want to listen to and trust your child. You can provide the food, and the child will decide if they want to eat. Strategies for responsive feeding include accept food refusal because they might not be hungry, guide portion size but don't focus on amounts, encourage independence, allow for self-feeding, accept mess, also have a neutral response to intake and refusal. You don't want to play games, you don't want to bribe or offer alternatives. Praise your child for tasting or self-feeding efforts, not for eating. Don't use emotional feeding to distract, comfort, or shape behavior. And don't allow TV while eating. So what's the importance of responsive feeding? It's that feeding takes patience and being frustrated at times is normal. Try to remember that it's important to create that positive feeding experience for your child. Next, I'll review infant and child feeding problems and solutions. So what is a feeding problem? A child may not be progressing through the typical course to independent feeding. They may have difficulty with effective, satisfying feeding experiences. They may stall or struggle to move forward accepting a variety of tastes and textures. And you may see a regression or sudden change in their feeding skills. So types of problems you may see are food selectivity, a chewing skill deficit, excessive fluid intake, insistence on eating only certain utensils and with certain utensils and dishes, a refusal to sit at the table, food refusal in general, a refusal to self-feed, and a refusal to eat in public places. Some associated conditions that are associated with feeding problems are cleft lip or palate, cerebral palsy, generalized hypotonia, congenital heart disease, gastroesophageal reflux disease, food allergies, constipation, and more. So what's the importance of addressing feeding problems? You want to ensure a nutritionally balanced diet because it's important for long-term physical health. It also has social benefits like the ability to eat in public. It promotes other skills as well, such as speech, and it decreases those unwanted behaviors. So how do we identify feeding problems? You can ask yourself these questions and see if any of them relate to you or your child. So what foods is your child currently eating? Does your child's diet match the family's diet? How much is your child eating? What is your child's meal and snack schedule? What and how much is your child drinking throughout the day? Where does your child eat? How is the food presented? How does your child react to new foods? Does your child insist on specific dishes or utensils? How long is a typical meal? Does your child become upset and display behaviors at mealtime? So for solutions and interventions, you want to create a goal with your occupational therapist. Choose a goal that relates to an immediate health concern, needs accomplished to meet other goals, is a family priority, and is easiest to achieve first. And your occupational therapist will help you do this. For treatment, there are behavioral interventions, oral motor treatments, physical and sensory treatments, adjustments to diet, methods for intake, and a combination of these approaches, again, that you can consider and that an occupational therapist will trial and error with your child. Next, a review on the connection between nutrition and childhood disorders. So how important is nutrition? It helps your child's brain and body develop. It enables your child to live a healthy life, and it maximizes their energy while minimizing illness. So nutritional problems fall into one of two categories. Either something is bothering the body or something is missing. Trust your gut and reach out to a professional if you feel your child is having a nutritional problem. Nutrition can play a component in something your child may be experiencing. So a review for gastroesophageal reflux disease, also known as GERD. So what is it? It's when food and acid from the stomach go back up into the esophagus, causing problems such as poor growth, vomiting, damage to the esophagus, pain and irritation in the nose or mouth, chronic coughing, and feeding problems. Signs include choking or wheezing, wet burps or wet hiccups, spitting up that continues beyond a child's first birthday, irritability or inconsolable crying after eating, refusing to eat or eating only small amounts, and failure to gain weight. Reasons a child may be experiencing GERD. The muscle tone around the stomach muscles may not have developed enough to keep the tummy shape stable and pressure off the door between the esophagus and stomach. Food can also irritate the gut lining, causing the stomach to get rid of it, which may be an allergic or non-allergic reaction. Solutions for GERD for children 12 months or younger. You want to remove potential irritants, usually in formula. Keep them in a vertical position after eating. Discuss and remain in contact with a pediatrician regarding diet changes. For children over age 1, consider removing dairy from their diet or switch to goat's milk. Consult a doctor when making changes in their diet and to reduce medications as GERD symptoms reduce. A review on celiac disease. Celiac disease is an immune disorder that occurs when someone has a food intolerance to gluten. Gluten is the general name for proteins found in wheat, rye, barley, and other grains. What causes celiac disease? It may be genetic, and it can appear with other disorders. It may also, someone may also have it and not know it. Signs of celiac disease include diarrhea, constipation, pale, foul-smelling stool, stomach aches, decreased appetite, weight loss, and poor growth. For diagnosing and treating celiac disease, you want to talk to your doctor if you see signs. Dietary changes may be necessary, such as a gluten-free diet. You also will need to find safe food options, and a dietitian can help adjust the diet, and an occupational therapist can help develop a mealtime routine. Next to review is my module on forming healthy eating habits. So what is healthy eating? It's eating a variety of foods so the child gets the nutrients they need for normal growth. Nutrients include protein, carbohydrate, fat, vitamins, minerals. The goal is to have a well-nourished child. So how much food is good for your child? A child typically eats the right amount of food at each meal. Children tend to eat the same number of calories every day or two. The pattern of calorie intake can vary from day to day. Don't expect your child to eat the same amount of food at every meal. How can you help your child eat well and be healthy? As the parent, you want to offer nutritious food choices at meals and snack times. Decide the what, where, and when of eating. The child can choose how much they want to eat of the food served and decide how much or even whether to eat. So how to have healthy eating habits for your child. You want to eat as a family. You want to make healthy food choices. You want to make meal times predictable. You want to have meals often. You don't want distractions during mealtime. You want to also form healthy eating habits early to develop a foundation for lifelong healthy eating and reduce conflict relating to eating. So a review on the food and drinks to encourage versus avoid at 6 months and on. So you want to encourage fruits, vegetables, whole grains, meats, dairy, water, about 4 to 6 ounces a day, breast milk, and formula. You want to avoid honey, unpasteurized drinks and foods, foods with added sugars, sugar-sweetened drinks, foods high in salt, cow's milk, and juice caffeinated drinks. So a review on the connection between nutrition and autism. So children with autism are more likely to have mealtime challenges, inadequate nutrition, and chronic eating problems. Casein and gluten-free diets can ensure adequate nutrition for children with autism. Lifestyle factors to consider include improving digestion, balancing blood sugar, increasing omega-3 fats, increasing vitamins and minerals, excluding food additives, identifying food allergies, addressing nutrient deficiencies, and ensuring an optimal intake of essential fats. To improve digestion, children with autism often have imbalances in the gut, which may cause irritability, decreased ability to concentrate, constipation, and diarrhea. Broad-spectrum antibiotics can also kill good and bad bacteria in the gut. Ultimately, it's important to restore a healthy gut, and you can talk to your pediatrician or occupational therapist to help. Next, I'll review sensory processing disorder in feeding. So what is sensory processing disorder? It's a condition that affects how your brain processes sensory information or stimuli. Sensory processing disorder, also abbreviated SPD, can affect all senses. A child might be overly sensitive to stimuli when other kids are not, or they may need more stimuli to impact them. Symptoms for an oversensitive child or someone that's sensory avoiding include certain food textures make them gag, they have poor balance and seem clumsy, they react poorly to sudden movements, touches, loud noises, or bright lights, and they have behavior problems. Symptoms for undersensitive children or sensory seeking. They may not be able to sit still. They may seek thrills such as jumping, heights, and spinning. They may spin without getting dizzy. They don't pick up on social cues or personal space. They chew on things, including their hands and clothing. They seek visual stimuli like electronics, and they may have problems sleeping. The cause for sensory processing disorder is unknown, but there's a possible genetic link, and there's a possible link between autism and sensory processing disorder. There is no official diagnosis for SPD. A parent recognizes abnormal behavior and talks to the pediatrician, and then occupational therapy can assess for sensory processing disorder and treat for it as well. So someone with sensory processing disorder may be a sensory eater. They may have sensory overload when eating, and they may be sensitive to textures, flavors, and smell of food. Food may cause them physical and mental discomfort. They may have unpleasant mealtime behaviors, and eating in public places may be challenging. They may also have severe fussy eating behaviors. Some tips and tricks for a sensory eater. You don't want to pressure your child. You want to address their fears and validate them. You want to try to make food fun and introduce new foods slowly and in small increments. Some occupational therapy activities for children with SPD or children with sensory problems. So messy play is a great activity. It helps them get used to how food, items, and drinks look, smell, and feel using their hands and faces. It engages the senses through play. It promotes tactile input and fine motor skills. It discourages picky eating. And messy play has 5 stages of progression, which is the child tolerates the food, interacts with the food, smells the food, touches the food, and tastes the food. Some activities for the senses. For touch, occupational therapy may introduce sensory bins with food. For taste, you can use a trying plate to have your child try a new food. For smell, you can talk about smells while finger painting with foods, such as pudding or whipped cream. For sound, you want to limit sounds in their environment during mealtime. And for sight, you can reduce visual distractions or oversensitivity and increase visual attentiveness for undersensitivity. A review on oral motor skills in feeding. So what are oral motor skills? They include awareness, strength, coordination, movement, and endurance of the mouth, jaw, tongue, cheeks, and lips. Oral motor skills are needed for eating purees or carrot sticks. The development of oral motor skills begins in the womb, and they are fully developed and established by age 3. And the impact of delayed oral motor skills includes oral motor delays and problems that lead to difficulty chewing or managing bolus, difficulty with speech, difficulty chewing, swallowing, and manipulating foods in the mouth, and it may affect the child's willingness to eat, and feeding becomes difficult and stressful. So some oral motor concerns to be aware of are jaw thrust, exaggerated jaw movements, jaw instability, jaw clenching, tooth grinding, stability bite, tonic bite, jaw retraction, tongue retraction, tongue protrusion, and tongue thrust. Some solutions include tongue lateralization activities, which are moving the tongue from side to side in the mouth, lip control, such as drinking from a straw, and chewing practice. And you can use these during snack or before meals. And you can also use oral motor exercises. So oral motor exercises and activities strengthen the function of the mouth, jaw, lips, cheeks, and tongue. They improve manipulation such as chewing, the movement of foods and liquids, tolerance of various textures, and swallowing foods and liquids. They improve coordination needed for sound production and articulation, and they also enhance oral awareness and oral discrimination. There are an abundance of activities to do with your child, such as blowing bubbles, licking popsicle, chewing on a straw, etc., to use to help improve those oral motor skills. Last up for the feeding review is a review of adaptive equipment for eating. So what is occupational therapy's role with adaptive equipment for eating? Occupational therapy helps children achieve success with feeding and eating. There are many great feeding products and eating tools available. Feeding and eating skills have a big role in children being more independent. Occupational therapy recognizes the role eating has on wellness and well-being, nutrition, and day-to-day functioning. And occupational therapy focuses on both the feeding aspect for nutritional intake and functional eating skills as well. So a little review of adaptive eating equipment. There's cups that address motor control and strength challenges. There's a variety of open cup, sippy cup, and straw cup options. Some are designed for those with dysphagia or aspiration precautions, and you want to consult a pediatrician or occupational therapist for children with thickness needs for safety concerns with swallowing when trialing cups. There are also plates and bowls available. They make eating easier. They help scoop food without mess. They help stabilize the bowl or plate. They make mealtime engaging. And again, you can consult occupational therapy for different options available because there are so many available. As far as utensils go, you can adjust handles on eating utensils. You can add width to the utensil handle and add weight or length to utensils. You can address the ability to hold the utensil. You can also address bringing food to the mouth and removing food from the utensil as well. And again, consult occupational therapy for different options available. Finally, I have adaptive oral motor equipment. So this equipment plays an important role in increasing the muscle tone and muscle strength in the mouth. It can improve biting and chewing skills. It builds oral endurance, mobility, and control. It provides sensory input for oral seekers, and it provides oral stimulation and cues to decrease oral aversions and normal oral sensitivities.
So for my part of the review, we're going to be reviewing the whole educational program around maternal mental health. So first we'll start off with postpartum depression. So postpartum depression is defined as depressive symptoms that last beyond 14 days after childbirth, and it can last up to a year, and postpartum depression can range in severity over the course. So after 2 weeks of experiencing depressive symptoms, they do diagnose it as postpartum depression. And then 70 to 90% of women have negative feelings or mood swings after birth, described as the baby blues, and that is depressive symptoms lasting shorter than the 2-week period. Overall, 15% of mothers will be diagnosed with postpartum depression, and fathers can actually have postpartum depression too, and they call it paternal postpartum depression. So we'll go over some symptoms, risk factors, and effects of postpartum depression. So symptoms include sleep disturbance, mood swings, anxiety, fatigue, and sadness. Risk factors include rapid decline of hormones, a history of mood disorder, untreated depression during pregnancy, which is antenatal depression, low social support or previous trauma, and then some other physical effects that depression can have on the body besides the mental symptoms include increased inflammation in the body, increased risk of heart disease, and increased chance of developing autoimmune conditions. So what can we do about it? So we want to know the signs and symptoms of postpartum depression and monitor those symptoms for either increase or worsening symptoms or a decrease. We want to create a plan of what we'll do if we know we're experiencing some of those symptoms, and also try to decrease the stigma by talking about postpartum depression and maybe finding either support groups or maybe some other women that struggle with postpartum depression. Next, we will review postpartum psychosis and intrusive thoughts. So psychosis can be thought of as to lose touch of reality. Postpartum psychosis occurs in 1 to 2 out of every 1,000 births. It is severe and rapidly evolving, so it can go from very little symptoms to very severe very quickly. The onset is usually within the first 2 weeks after delivery. And some symptoms someone may experience with this is hyperactivity, agitation, bizarre disorganized behavior, insomnia, delusions and hallucinations, which are unique to this diagnosis, poor concentration, flat affect, delusions of control to harm the baby or yourself. And they don't know the exact cause of postpartum psychosis, but they think it can be caused due to the rapid change in hormones or overall stressful life events. Some risk factors for developing postpartum psychosis include previous bipolar episodes, psychosis or postpartum psychosis, a family history of postpartum psychosis or bipolar, sleep deprivation, perinatal infant mortality, complications during labor and delivery, lack of partner support, and overall increased environmental stress, which this could include having a child that has a delay or diagnosis. So we'll discuss some intrusive thoughts, and this can be a comorbidity of many types of mental illness and actually be something everybody experiences at some point in time. They can be defined as mental events that interrupt the flow of task-related thoughts in spite of efforts to avoid them. It affects 70 to 100% of new mothers and 80 to 99% of the total population. The thoughts can consist of doubt, decisions, identity, safety, death, or religion. Some common topics people might think about with these thoughts are accidents, contamination, or intentional harm. And something you can think of if you're having trouble deciphering if you are having an intrusive thought is think, is this a usual thought for you? Is it bothersome? And does it feel hard to control the thought? If so, it is probably an intrusive thought and not an intentional thought. Next, we will review postpartum anxiety and postpartum OCD. Postpartum anxiety can be thought of as excessive worry that is accompanied by restlessness, fatigue, poor concentration, muscle tension, and sleep disturbance, and this is present after birth. It affects 10 to 18% of new mothers, and 14% of mothers with postpartum depression also have postpartum anxiety. Symptoms of postpartum anxiety can include excessive worry about your child's development or safety, feeling of being on edge, feel a sense of danger, have insomnia, changes in heart rate or breathing, nausea, and dizziness. Risk factors include personal or family history of anxiety, low social support, having a crisis in housing, job, or finances, history of endocrine dysfunction, which can include thyroid or diabetes. Next, we'll discuss postpartum OCD. This can be thought of as intrusive images or thoughts, as well as repetitive behavior or thought patterns, which we call compulsions, that are aimed at reducing the anxiety. So 3 to 5% of new mothers and some fathers are affected by this, and approximately 27.5% of women have a comorbid anxiety disorder. Symptoms can include unwanted thoughts or images of harming the baby, feeling overwhelmed by obsessions and compulsions, which is unique to postpartum OCD. And the compulsions are hard to control, and those are tried to aim at preventing the fears from coming true. So risk factors include personal or family history of anxiety or OCD, personal history of obstetric complication, depression, family history of mood, or substance disorders. Next, we will review birth trauma and PTSD. Birth trauma can be defined as distress experienced by the mother during or after childbirth. Trauma can be physical, such as a birth injury, but it's often psychological and emotional. And with trauma, a mother may feel threatened, a fear for her safety, have an unexpected complication, or have an experience that was different from her vision. 1/3 of all women describe their birth as traumatic, and 1/2 of all women who have birth trauma will develop postpartum depression. Next, we'll discuss postpartum PTSD. This can be defined as a psychological reaction occurring after experiencing a highly stressing event, such as wartime combat, physical violence, or natural disaster, or in this case, birth trauma from childbirth or pregnancy, and it's usually characterized by depression, anxiety, flashbacks, nightmares, and avoidance of the event. 0.8 to 6.9% of women will develop postpartum PTSD due to that birth trauma. And 0 to 21% of women have postpartum PTSD. Birth trauma events can lead to postpartum PTSD, and women will develop those symptoms due to experiencing birth trauma at some point during their pregnancy or childbirth experience. So when we're discussing symptoms surrounding PTSD, they like to group them in 3 groups. So we have intrusion, avoidance and numbing, or hyperarousal. So under intrusion, we have nightmares, flashbacks, and intrusive recollections. Under avoidance and numbing, we have avoiding feelings of conversation, isolation, or decreased affect. Under hyperarousal, we have insomnia, anxiety, or irritability. So you may have all of these symptoms, or you may have a few. Risk factors include social isolation or divorce, history of abortion or infertility, having a long labor, which can be subjective, obstetric complications, and having high anxiety during labor or during your stay at the hospital. So what can we do about birth trauma and PTSD? So before birth, we could educate ourselves on risks and what to expect during the labor and delivery process. We could create a support system and also have a birth partner or midwife present. And after birth, we could express how we feel to help our mental health, talk about our feelings with others. We could monitor our symptoms for new or worsening symptoms. We could try cognitive reappraisal, which is thinking of the positive aspects of all situations. And of course, we could talk to the doctor about treatment options or further medication. Next, we will review mental health impacts on caregiving and child development. So how does maternal mental health impact our ability to be a caregiver? So it can affect our relationships, which can cause disengagement, higher conflict, lower affection, and higher dissatisfaction overall. It can cause bonding impairments between you and your baby. So bonding at 12 and 15 months of age is impacted when the mother has depression at 6 to 8 months postpartum, according to a study. And it can cause avoidant attachment between your child and you. And next we have attachment overall with your child. So your attachment might be withdrawn. There might have mood swings. You may react negatively. Insecure attachments are possible between you and your child if you're experiencing mental health symptoms. And overall, children need a secure attachment, so that is why maternal mental health has such an effect on the attachment style between you and your baby. So how does maternal mental health impact child development? So it can impact sensory. So high antenatal depression and anxiety equaled the child was more sensitive at 10 and 14 months of age. And then more severe postpartum depression led to a child with greater sensory needs at 14 months of age. It can impact behavior, so a child might have higher antisocial behavior. Infants might cry longer and for longer durations. It can actually predict more shyness, depression, and anxiety in children. It can impact their cognitive functions and sleep. So mothers with no postpartum depression had children with better object concepts at 18 months of age, which means if you were to, say, cover up a toy with a blanket in front of your child, they would know that removing that blanket, they would find the toy. Some children, that is not developed as quickly, or they're not able to grasp that concept as easily. Mothers of boys who have postpartum depression, the child scored lower on the McCarthy scales of children's abilities, which measures fine motor and gross motor skills, as well as cognitive functions. And postpartum depression can lead to child sleep difficulties and sleep anxiety. So what is the overall effect of maternal mental health on caregiving and child development? So the child could have more global developmental delays, a more negative affect. They could have language delays, less sustained attention during tasks, increased behavior, and also a high activity level. So what can we do about it? So we can try to create a positive environment. We could use positive reinforcement with your child, which is using high praise when they demonstrate a good behavior. We could take time to think before reacting. So if we know our mental health is not great that day, just taking a minute to react to a situation. So maybe we can have a more positive reaction to the event. We can create social support, talk to a therapist, and continue practicing self-care. Next, we will talk about parental involvement in early intervention. So what is early intervention about and why is it important? So in early intervention, we provide evaluations, ongoing assessments, service coordination, interventions within the home, support services, IFSP collaboration, and we try to increase parent efficacy. So why is parent involvement important in early intervention? So EI is routine-based, and it is based around the parent's schedule or the routine of the household. It's parent-mediated, which means the parents discuss and create all of the child's goals. And parents have the most important influence on a child's early development. So they are with the child the most. They have the most opportunity to provide educational interactions throughout the day. And parents are coached through activities. So parents identify the goals and priorities for their child, and then the parent and therapist will work together to create activities and a plan of action. And therapists are there to teach you skills and strategies that you can feel confident doing outside of therapy sessions. So how does maternal mental health affect parental involvement in EI? So how parents interact and respond to their child affect the child's development, communication, and social emotional well-being. So poor mental health in mothers is associated with them being less responsive and sensitive to their baby's cues. Parents with maternal mental health are less likely to follow routines and also less likely to engage in early learning activities in the first year. And carryover increases success and helps the child benefit fully from services. So what can we do activity-wise for a good mental health day? We could make a craft with scissors and glue, do some sensory play, make an obstacle course, draw and color. And then for bad mental health days, we could do tummy time, counting, reading books, or singing songs. And all of these activities could greatly impact your child's development. Next, we will review coping with maternal mental health. So why is coping education important? A study shows that women that cannot identify the cause of their postpartum mental health were more likely to use all three forms of coping negatively, and we will discuss the forms of coping. Failure to cope can lead to the continuance of maternal mental health symptoms and episodes, and it can cause weak attachment to the fetus during pregnancy or child after childbirth. So the types of coping include problem-focused, emotion-focused, and dysfunctional or avoidance. Some healthy coping strategies would be meaning-making, nurturing oneself or self-care, seeking support and connections, and raising awareness. And then unhealthy coping would include avoidance, so denial, blame, distancing, and disconnection, which can be distraction, venting, and self-blame. So if we're lucky enough to prepare, is there a way we can prepare to have healthy coping? So yes, we can think of pleasant thoughts, we can educate ourselves on importance of contact with others, we can find activities we enjoy, and we can learn to evaluate our feelings daily and ask for help. So how can we develop healthy coping skills? So what coping skills worked well for you in the past, or what do you enjoy, can be the first step. Next, you want to develop a plan for the coping skill. So what feelings will trigger this coping skill, and when will you practice this coping skill? And then the third one would be to practice that skill daily and treat it as a daily chore. Next, we'll discuss activity-based coping, natural remedies, and stigma. So for activity-based coping, we can have aerobic or non-aerobic activity, which can be walking, running, weightlifting, or maybe coordination training or flexibility training. Next, we have gardening, which can improve mental state, increase socialization, and increase physical activity. Next, we have yoga, which can improve anxiety and depressive symptoms and also increase cognitive functions. And we have mindfulness, which can alleviate depressive symptoms short-term, and it can provide benefits to postpartum women as well. What are some natural remedies we can use for short-term symptom alleviation? These are not used to treat any mental illness. So lavender tea can reduce fatigue and depressive symptoms and increase bonding with the baby. Turmeric can reduce markers that are upregulated with depression and improve overall mood. Omega-3 fatty acids can balance chemical reactions in the brain. It's also an anti-inflammatory. And then vitamin D, 2/3 of all women have a deficiency, which can increase depressive symptoms. And it reduces depressive symptoms and fatigue when it is taken daily. So next we have stigma. So the first type of stigma we have is internalized or self-stigma, and this can impact self-efficacy or confidence in parents, and mothers have significantly higher internalized stigma than fathers. Next is treatment stigma, which can be stigma surrounding prescriptions, counseling, herbal remedies, or spiritual counseling. Next we have stigma surrounding seeking mental health treatment. Research shows that those who seek professional help are stigmatized more than those who do not, and many avoid treatment due to the label of having a mental illness. Next, we have perceived stigma, which is the perception of being stigmatized by others, and experienced stigma, which is experiencing the stigma directly, and this can lead to avoiding help, withdrawal from treatment, and avoidance of treatment. We can reduce stigma by providing accurate portrayals of therapy, educating yourself and others with reliable sources, and having contact or peer support with others. Next, we will review increasing parenting confidence. Low self-efficacy in parents can lead to increase in depression symptoms, more controlling parenting behaviors, behavior difficulties in children, higher stress levels, and use of poor coping, and high confidence or self-efficacy can lead to being sensitive and responsive to your child's cues, active parent-child interactions, utilizing healthy coping skills, and creating a happy and nurturing environment. So why is it important? So self-efficacy can influence your child's psychological development and impact your mental health. So education on parenting styles, discipline, positive interactions, and development can help improve parenting confidence, which is what we'll discuss next. So we have parenting styles, and some different styles include authoritative, authoritarian, permissive, and neglecting. And here I have listed the different levels of demandingness and acceptance. So authoritative would be the ideal parenting style, which is a high level of both demandingness and acceptance. For discipline, we have the cognitive approach and the behavior modification approach. The cognitive approach would be disciplining your child and then providing the child with a rationale as to why they are being disciplined. The behavior modification approach includes providing positive reinforcement for good behavior and negative sanctions for misbehavior. And then for positive interactions, we have giving your child compliments, praising them, doing an enjoyed activity with the child, and active listening. And having positive interactions can lead to higher confidence in the child and actually lower depressive symptoms in the parents. An aspect of increasing parenting self-efficacy was knowing basic development progression. So here I have basic development of a 1-year-old, 2 years old, and 3 years old. So for 1-year-old, your child should be able to put items in containers, understand no, start waving bye, picking items up with their thumb and their pointer finger, and walking holding on to furniture. At age 2, they should notice others' emotions, pointing to items in the book when asked, pointing to or doing 2 things at once with a toy, saying 2 words together, kicking a ball, running, or eating with a spoon. And at 3 years old, we have playing with other children, asking who, what, where, and why questions, drawing a circle, stringing items together, and using a fork. So obviously every child develops differently, and not every child will hit every developmental milestone, especially if they are developmentally delayed in some areas. So this is just education to provide a basic progression of what skills should come and what skills come after that. Next, we'll be reviewing social support. So why is social support important? So it's associated with higher depression scores among women. A lack of social support is also an indicator and risk factor of postpartum depression and other mental illnesses postpartum. Social support was shown to play a significant role in women's health at 8 weeks postpartum, according to a study. Gathering support before birth can reduce early postpartum depressive symptoms and enhance postpartum recovery. And social support can be found by pursuing a hobby, volunteering, becoming a member of a national group, help from your EI therapist or doctor, and many different ways. So here I have some types of social support. So we have relational or emotional support, and that can be providing encouragement, empathy, and sympathy. Informational support or advice would be guidance, suggestions, and useful information. Instrumental, tangible, and physical support would be babysitting, cleaning, and/or running errands, or maybe even providing financial support if needed. And then we have esteem or positive messages support, which would be promoting skills and abilities in someone else, providing compliments, and also providing validation. So a part of having social support or peer support might also be being a part of a support group. So the benefits of support group include supporting each other, helps with decision making, provides empowerment, increases feelings of acceptance, and improvement in self-esteem. And they function by having reliability on a community of individuals when in need. It can be an outlet for physical and emotional stressors, and it provides disclosure in a safe environment. So at the end of this presentation, we'll have all of our references that we used for this PowerPoint, and a majority of them we also used throughout the course of the educational program. But this concludes our final educational program module, and we appreciate everyone for their participation and support. And of course, if you have any questions, you can message us or reach out to us with any references or any specific questions. But thank you very much.